India is one of the first countries in the world to have a national cancer registry program and a national cancer control program. And I'll tell you at the end where we are really lacking, where all of our cooperation is needed. But I will also tell you what we have achieved, and this is all documented. Cancer nowadays is an evidence-based medicine practice, so there is nothing, guesswork about it. So what we have done, I'll let you know that. Oh, great. This is the global scenario which you have heard from the morning. Since this is a global conference, one slide about that. Huge problem. Cancer is now the #2 killer. If somebody says, we are all sitting here, how are you going to die? We're not going to die of infectious diseases, most of us, because infectious diseases are almost cured. We'll die of 4 things. Cardiovascular disease, cancer, trauma, because we have produced so many cars, the roads are getting choked, so there is a lot of chance of all of us dying of trauma also, and stroke. So these are all non-communicable diseases which is producing death, and we are very rapidly becoming westernized, though we are not westernized, but we are very rapidly becoming westernized. That's the figure. Second leading cause of death in the developed world, third in the developing world. We say we are developing world, and in fact, India, if you see, we are all 15% people filthily rich. Their amount of wealth is more than Europe, but 45% people don't have food to eat also. So we have to see everybody, see that, the science works for everybody, and science is the solution also. And by WHO says by 2020, we will have 100 lakh deaths in a year. That's quite, horrifying. This is our scenario, our own data, but let me tell you, this is extrapolation of only 10% of the population. That's our state of affairs. Only 10% of the population are registered for cancer, only 10%. Because people are not interested to take it up, because no work, no mistake, some work, some mistake. People don't want to work, so nobody wants to take this job, because this is an extra job for people. And unfortunately, this is in Bengaluru, and 10% of the country's population only are covered. So this is a gross extrapolation of 10% of the data. But this is what it says. 30 lakh cases at any time. Today, if somebody asks, how many cancer cases are there in the country? 30 lakhs. 11 lakhs every year, and 6 lakhs die. That's a huge percentage of death, very, very huge. So many people should not die. And the great thing is that if you see this, see, 50% of the people, 50% of the cancers are preventable. Tobacco, if somebody doesn't take tobacco, he will not have oral cancer, very simple. 50% tobacco related, sorry, 30%, 20% infection, that's the world figure. Our cervical cancer is an infection-related cancer for which a vaccine is there now, HPV 1618, hepatitis, your stomach cancer, Epstein-Barr virus, 20%. 20% is infection, totally preventable. 50% preventable cancers. And worst is this, that 2/3 present in advanced stages. As I told you, 80-20 formula, 80% present late, out of which only 20% is curable. So that's our problem, we need to sort it out. If you see, I advise the government of India, so I have some access to the files. So these are some good files which I could get from 1930-31, when British was here. During British period, these were the causes of death. And as you can see it, top 10 causes of death did not include cancer. How we are dying in 30-31? Cholera, smallpox, plague, fever, they used to call rural fever, diarrhea, dysentery, respiratory disease, and lifespan was less than 30. Today, lifespan is 70 years. So we have improved, but we have a lot of problem to sort out. If you see these were the cancer centers those days. 8 cancer centers in 30. All over the country, only 8. And 7 are in India, 1 has gone to Pakistan. This is the hospital, Lady Willingdon Hospital has gone to Pakistan. The other hospitals were in India, and very few. They used to be called radium centers, because chemotherapy as a subject was not available, because it started after the Second World War. And surgical oncology was anyway being done, but cancer centers were called radium hospitals. The time is towards that side, so I don't know if you could tell me 5 minutes before. The time is facing towards the chairperson, actually. So I was to see there. Can't see from, yeah, that's better. Well, this is our National Cancer Registry program, which started quite early in 1982. This is similar to SEER program in the US, a very effective program. Whatever data we have, that is solid data. But we are extrapolating too much. I'll show you example. For example, we didn't have Northeast as initial coverage in the registry. When we covered, we knew that the highest incidence happened to be in Aizawl, 273, versus 40 in B.R.A. It is 7 times in the same country. So our countries would have been called United States of India, so far as cancer is concerned, because it is so different. So much of difference is not available in any country. So the cause of cancer is in India also. We know why in B.R.A. in a village, the cancer rate is so low, 40 per 100,000. And there it's 280 per 100,000. So, I mean, it's obvious. So if the time permits, we'll discuss. And this center was expanded to a center called National Center for Disease Informatics and Research. This cancer registry is one of the most established registry. Seeing the success of this registry, government has added 3 more diseases: diabetes, cardiovascular disease, and stroke, because all 3 are also non-communicable diseases. So that one could have a common approach towards the registry and also solution, because there are common etiological factors like tobacco smoking, unhealthy lifestyle, more of fatty food intake, less of exercise. So government has a program also. I'll tell you that in a minute. Well, this is our National Cancer Registry program details. We have only 29, surprise, only 29, okay, only 29 population-based registry, only 29. We have 35 states and union territories. There are big states which are missing. Big states which are missing, which needs to be done. Hyderabad was included last year with the only, effort of Dr. Raghunath Rao. And he was the only person, because you have to move, nothing moves here. You have to push things there. He had to go to this office, that office, enumerators, registry. You have to get the basic population figures, age-wise population figure. But somebody has to do it. God won't do for us. We have to do ourselves. But it gives fantastic data which we can utilize for the cancer control program in the country. If you see the hospital-based registries, we also have 29. Hospital-based registries give us a figure depending on, okay, hospital-based registries give us a figure how that hospital, see the patient. Somebody has a neurosurgery, specialty there, you will have more brain tumors. But the population-based registry of that area, we take as a person who has stayed there for more than a year. So he belongs to that place. So he will have that habit. Habit of that place, like B.R.A. B.R.A. is a village, so the people have been staying there for generations. So hospital-based is only about the hospital, but one can do studies about survival, how our patients are surviving, and we have started that also. This is our network. As you see, there are huge areas in this country which are lacking. In the center, east, these areas are all lacking, This is the figure I have been quoting. If you look at this figure very carefully, you'll see that 273.4 is in a place called Aizawl, which is the capital of Mizoram. And here it is B.R.A. B.R.A. is in Solapur district, Maharashtra, a pure village. And this figure is for last 20 years. 20 years, I'll show you the data, for last 20 years. So there is some cause. Those causes we can discuss. This is again regarding the females. Well, these are the hospital-based data which says which are the common cancer. We cannot say, if somebody asks which is the commonest cancer in females in India, we will have to guesstimate because there is no data of India. So we have to extrapolate. So today, if we say which is the commonest cancer in males in India, we say in Mumbai this is this, Bangalore this is this, Chennai this, Delhi this. But common ones are mouth, lung, tongue, esophagus. And in females, it is breast is coming number 1 now. Cervix is gradually coming down. I'll tell you the figures after that. Then ovary is rapidly going on. And then gallbladder. Yesterday, I think today somebody was mentioning, if you see gangetic belt and the northeast. Gallbladder is very high in females. And gallbladder, as you know, is a very bad cancer, present in very, very advanced stages. We say they're present not only stage 4, they're present in stage 10 probably, where nothing can be done. Well, these are our figures. If you see, this is about, mouth. Every cancer is increasing. If you see about the incidence of cancer in all registries, these are all big registries, as you see, Bangalore, Chennai, Delhi, Bombay, all registries, except one. Even though we don't have an organized screening program, but the cancer control program, which has been there since 1982, that has given a lot of support to the country, and because of that, the cervical cancer has definitely come down. How do you see that? This is cervix. Cervix has definitely come down. Gradually, it's coming down. In fact, just in Delhi Cancer Registry, 15 years back, cervix was number 1. So now, cervix is less than half of breast. That means people are getting educated. See, we were discussing what is the cause of cervix and breast. What God has done is, causes of breast is just opposite of cervix. Cervix, poor socioeconomic status, more of chances of HPV infection, staying in jhuggi-jhupdis, not enough access to water. We say if somebody has enough access to water, why there should be HPV infection? How many people can afford the HPV vaccination? And breast is just opposite. Higher socioeconomic status, late age of marriage, late age of having the first child, no time to have the breastfeeding. But, that's the Western data also, so we are getting very quickly westernized. Well, this is our evolution of the National Cancer Registry Program. 75 it started, and then now we are in 2012, and a lot of improvement has happened. In those days, 75, initially started with 10 lakhs, only 10 lakhs. Today, if you see, Dr. Linge is here, he's the chairperson. They have got 120 crores. 120 crores. There's no discrimination. Even Tripura has got 120 crores. I think in the city of Bangalore, there will be 20 Tripuras, population-wise. But state, every state has to get this thing. So money is not a problem in this country. Anybody who wants money, money is available. But the question is, you cannot say, I'll sit here and, money will come and government is not doing this, not doing that. If anybody approaches, we are having a new cancer center very close to Delhi. We have got 5,000 crores in 2 places, no problem. But the question is, somebody has to do, somebody has to be after that, documentation has to be done, process has to be complete. Okay, so these were the various features in the from 1st January 2005, we had recognition of new regional cancer centers and strengthening of the existing cancer centers. By that time, the grant had increased to 50 lakhs per center. And at that time, the outcome was that we have 640 districts in the country. Out of 640, 100 were supposed to be enrolled, and one could not include all 600 because, see, to get the grant also, one has to spend the money and give the utilization certificate. Half of the people don't give the utilization certificate. So that becomes a problem. There are some rules and regulations of the government. You cannot just keep on somebody giving the money without getting what he has done with the previous amount of money. This manpower was supposed to be produced like surgeons, physicians, radiation oncologists, nurses, and cytotechnician is a big problem in our country. Because if you have to do a cytology in the periphery, you require cytotechnicians. And district level, improvement was supposed to be there. And these are our regional cancer centers. There are only 2 states which have 2 regional cancer centers, Maharashtra and Tamil Nadu. Otherwise, every state, not every state has a regional cancer center, but Kidwai in Karnataka, Dr. Linge, the director there, is a regional cancer center, and that is supposed to oversee the improvement of other centers. And this was the improvement by 2005. We have to have some indicator. This was the publication at that time by Dr. P.S. Iyer. We had, by that time, 76 telecobalt units, very, very old, 35, telecobalt units which are 15 years old, and we had linear accelerator coming by that time. And now, today, if you see in 2015, what we have is we have total number of radiotherapy centers 360, teletherapy is 545, significant improvement. And I'll show you Lot of machines are being manufactured in Bangalore itself. In fact, periphery of Bangalore, Kollar, we had gone there to see. There is a company called Panacea. There are many companies who are doing many jobs in the, lot of indigenization is happening. I'll tell you in a minute. And this is the machine which is getting manufactured. They're manufacturing linear accelerators, cobalt at a cheap cost, very, very cheap. 45, cobalts are installed in this country. We are, also manufacturing treatment planning system in this country. Under the Joy Bigyan program of the Prime Minister, linear accelerators are getting manufactured. So a lot of good things are being done, but we require everybody's support. It's not a one person's job. What our cancer registry program has done is, we have our own pattern of care and survival studies. How our patients are behaving. Because our patients are coming late, they're late stage survival poor. But you'll be surprised that our early stage patients also do the same way as the West. So this is one of the publications of our very recent publications. And these are, if you get proper therapy, people don't come for proper therapy because somebody's farming is affected and all that, those details are there. And in the policies, seeing the effectiveness of the cancer control program, the cancer control program NCCP has become NPCDCS. It's called National Program for Control and for Detection and Control of Cancer, Diabetes, Cardiovascular Disease, and Stroke. And this, our National Cancer Registry program has become National Center for Disease Informatics and Research, collecting other 3 data, so that at least data is there. Unless you have data, how do we progress? Well, this NPCDCS, all the 4 diseases, chronic diseases, cardiovascular disease, stroke, diabetes are combined because they had similar etiologies. Practically, if you read them, alcohol, obesity, and not having enough exercise, they are all similar. So from a control point of view, from a public health point of view, you can have similar studies. If you are going to talk to somebody about health education, why not talk about all 3? Like tobacco, it causes, chronic obstructive lung disease, it causes cardiovascular disease, and also cancer. And well, these are the factors which you can look at, like behavioral, one can look at tobacco, alcohol, physical, physiological, and disease outcomes. I have 2 more minutes left. And what has been done is, in the district level, this is what has been achieved. Some districts who have accepted the money have been given basic facilities like cytology, X-ray, dental chair, and in 5, one has a big radiotherapy center. Radiotherapy, radiodiagnosis, and nuclear medicine are the costliest, departments. They are like elephant in a zoo. You can't have zoo without elephant, but you can't give elephant the same food as you give to the monkey, because elephant will die. So the question is, these facilities take almost 90% of the budget, but that's it. You can't help it. Probably in future things will get better. And from the CHC to the tertiary cancer center, we have a program, and you see this is the government order, which according to which Dr. Linge also has got, and 8 centers have got 120 crores last year. Some more will get this year. Anybody who gives the utilization certificate gives justification, and 120 crores will be given to 20 cancer institute, and 45 crores will be given to 50 institutions, 15. So money is not a problem. We say money is not there. India is a poor country. Who says India is a poor country? Some of the Indians are poor. Even in US, you can ask Dr. Kapil Mehta here. Say, US also 45 million people don't have insurance. They are also poor. So the question is, we cannot say till the last man has food, we will not do science. So we have to go on, carry on, with the program, national programs. And what have been the achievements? Less than a minute. We have established new cancer registry. This has showed much lower rural incidence. Rural incidence has come down. Cancer management facilities have improved. We have now a lot of PBCRs. Decreasing incidence of cervical cancer is a very, very important thing in poor people. And yet to achieve, that's very important. This is required for our younger colleagues. We have only 10% registration, like we have 5% insurance in the country. 5% of people who are really insured. That can wait, but without registration, we don't know what's happening in that particular area. And we don't have registries, even in big states, adequate infrastructure, state-of-the-art facility, more health education, more indigenization, so cheaper. We manufacture cities, Professor Kakaral, Subbarao know that under their leadership, CT, in this white field itself, CT, ultrasound, X-rays, everything is manufactured in this country. The only thing is, we say no, it's Indian. Indian machines are better. I can tell you on record that our cobalt machines which are being produced in this country are better than Theratronics which is produced in US. Because our cobalt machine has a jaw size which goes up to 0 by 0. So no accident related problem. There it's up to 3 by 3. That means you will have some exposure. So our systems are really good now. And we have to set priorities for cancer research for which this new center is coming. Like, we have, there are our special problems, which is not a Western problem, we have to sort it out. Germany is not going to sort out our cervical cancer problem, or gallbladder problem, or esophagus problem in the Northeast, and thyroid problem. So this we have to sort it out. And thank you very much.